see me?
I hear you. That's fantastic, Anna. Okay, so
Okay.
why don't we get started? Because we've timed every minute of our time together. So I have to say, like, this is so amazing to see all your faces. So everyone, for the first part, why don't you leave your screen on so we can see each other? We're kind of face deprived. I haven't seen many of you in years, it feels like. Hair has grown, your beards have grown. All right. Have your coffee. We have a break in 1 hour. So I have water, coffee. This is a coffee date together. The way we do it now, right? Virtual. Here's my virtual mug. Okay. So, we are all here. We have over 100 of us. We are, this is our biggest ABMR meeting, right? Usually we have 50 to 70. It's a very small society. And we now have our new members that will be voted, that were just voted in, that Mustafa will introduce. We have our early stage investigators. So we're kind of having a prequel meeting to our in-person meeting next year. Everything is frozen in time. We have the same meeting agenda in almost exactly 1 year from now, where we can be together in person. We have frozen the ABMR leadership so that you're stuck with me for another year and all the ABMR council. And we're planning really intensely for what we're going to do in the future. So that dialogue is starting here now. It is, ABMR is such a wonderful family. And if you look around, we have some special guests and welcome. Many of you are going to be with us next year when we focus on geroscience. I see Ron Kahansky, who is one of the heads of NIA's Basic Division of Biology. Thank you for joining us. Liz Blackburn will be joining us later. We have a lot of special guests who are getting to know us now and will be with us next year. So the magic to ABMR is we really help each other. We optimize our science, the quality, the impact, and we don't do that just through information sharing. It's really about relationships and being together. And so I really hope we can be together next year. All I'll say about next year is that we don't know where we're going to be in a year, but we are planning and assuming that we will all be together in person in Santa Cruz at 1440. They will have changed everything. It's mostly single rooms. We'll be the only people at the resort. Most likely it's going to be us in the new world, right? We'll probably be slightly socially distanced. We'll see. So if you plan on going, you need to sign up now because we have about 15 rooms left. And the rooms are about 300 or 350 a night. And the retail price is $900 for next June. So it's unaffordable for us academics. So get in now. We hope you come. Okay, so this is just an amazing moment and time to be together. We wanted to do a virtual meeting, even though we're just cardboard figures, but it's so amazing to hear what our colleagues are doing at this moment in history. Our work is, as Paige said in our letter to you, our work has never been more important. We are seeing the consequences of the global pandemic in magnifying and exacerbating the social inequities and the health disparities that we have been studying for decades. Right behind that, we have the larger but almost invisible context of climate change, our more serious problem. And then the economic consequences of this time are now with us and longstanding. And underlying this, enabling these terrible things to happen to our population health is racism, is institutional, systemic, decades of racism that has now been looked at with fresh eyes. And I think for many of you, and I'll say certainly for me, thinking I understand it and knew about it, I have, where we are, we planned this meeting a month ago is very different than where we are today. And I have new, fresh vision with all of its surprises and discomfort about my role, about our institution, about how we find and train our next generation of colleagues. And so it's a really wonderful time for us to be together and look at our role and what we can do in our own microcosms, in our institutions, in our research programs. So part 2 today, we'll get a chance to discuss the future of behavioral medicine in this new world, in this context. I think that the pandemic is also an opportunity, another demonstration of the importance of our work, because we don't understand who gets sick and who dies beyond some very crude factors, such as who already has disease, such as socioeconomic vulnerability. And so we have this opportunity because of what we study, the biobehavioral factors that predict individual differences. We are ones who come into research programs and help people connect the genetic, the biological vulnerability, the biobehavioral, and the social. So there are so much that we will find out from each other and from the field in the next year. And we will have in our program next year an opportunity for us to really step back and examine what's happened this year from our own interdisciplinary perspectives. The race equity movement has given us this opportunity for phenomenal change. It is incredibly stressful, especially for our brown and Black colleagues. And it's a time, it's a little window of opportunity for us to be as active as we can, because all of a sudden, instead of studying the end products of health disparities and trying with our behavioral interventions to move them, we have an opportunity to influence the causes of the causes, the social determinants of biobehavioral health. So I'm just observing and taking in and trying to figure out what to do next. And I, rely on all of you to see what you're doing and thinking too. So let us begin. I want to just thank everyone who has built up ABMR over the decades. And I want to point to history before we move on. We have a lot of new members and potential members. 42 years ago, ABMR began with a very esteemed group of 35 members. The charter is on our website under announcements. I read it this year and I was stunned, both by the wonderful vision and people, and that the fact that they were 35 white men. It took 20 years before ABMR had a female president. Who was that? I'm looking at her right now. You're in my Brady Bunch box. It was Margaret Chesney. Margaret Chesney and Karen Matthews have written up a perspective for us, just posted yesterday on our website, that helps us understand where we are now and where we've been. And Title IX was incredibly important. Margaret, with her amazing accomplishments, couldn't get into graduate school until post-Title IX. So there are, just pointing to policy changes that we want to have our eyes on when we're thinking about research and presenting results. We have Steve Weiss here, I believe, and he also has a piece of history on that website that is going to guide our future. It's still very important. So I'm going to turn this over to Paige, and I also want to point to Joe Schwartz. This has been first month of pandemic. All of you were wondering, what are we doing for ABMR? We didn't want to play a game of chicken and try to wait till they canceled, which wasn't until recent. And so we got out of our contract. We needed legal help. Thank you, Tika, for finding us help. And Joe was just my hero. I mean, I couldn't have gotten out of this contract without Joe's work, reading so many versions of contracts and helping us through this. So that was a new kind of stressor, and I couldn't have done it without my great colleagues. So thank you, Joe. Okay, so now I'd like to turn it over to Paige, who has really been fostering ABMR for years. She has a very high involvement role as secretary. We've convinced her to carry on another year, and we need new members to be involved in council and take on different roles. So I just want to plant that seed for all of us. Okay, Paige.
Hi, can you hear me? I've been having substantial technical difficulties, so I apologize if I appear frazzled and unprepared, because I really went through the ringer this morning trying to get this fixed. But I'm so happy to see many friends and colleagues and those that I had admired in the field of behavioral medicine for decades. It was with great dismay that we, had to cancel our meeting, but we as behavioral medicine researchers and public health practitioners and clinicians absolutely know that it was the right thing to do. And I just want to take this time to just applaud the leadership of Elissa, Epel, and Joe Schwartz and Martika Hall, because they really worked tirelessly to really the protect ABMR and to make sure that we will continue to stand as the premier senior professional society for behavioral medicine. So if we could just take a moment to substantially thank them as well as the other members of the Leadership Council because they worked tirelessly to make sure that our cancellation of our annual meeting, which is of course the main function of our academy, that it did not make us come undone. So we're looking forward to having this time together for this short period of time with prestigious colleagues that are going to sort of inform us about their research efforts as it relates to COVID and other very time-sensitive things. I'd be remiss as an African American woman if I did not relay, again, my substantial grief, anger, yet hope about the future, about our current situation and about the future. Hope for me and faith for me is absolutely essential in everything that I do as a woman of color. It is the only way that I can remain standing. And I just need my colleagues of all colors, shapes, sizes, and hues to come together because when any one of us, any class of us is dehumanized, it really, really dehumanizes us all. So this is really an opportune time for ABMR to, use our mission to really move forward on things that are of critical importance to our society. And we have the absolute, great leadership in Elissa to carry us forward for the next year. So there are a few things that we will need to discuss as a membership as it relates to elections, which we postponed this year, and those that are currently on council, given how much disruption had occurred in all of our lives, we made the decision within council to just delay our elections until next year. But we can have a larger business meeting in which we inform you of the work in more detail that the council has been doing to make sure that we're able to continue our mission and to actually to come out stronger as the senior professional society for behavioral medicine on the other side of this. So with that, I think I'll stop and I'm looking forward to the presentations and our dialogue. Elissa, was there anything else that you wanted me to speak to at this moment?
Just a huge thanks to you, Paige. You're the reason that that I joined council, and
I'm just the worker bee, so no. It gives me great pleasure to be able to work with Elissa and others to sort of keep our academy afloat. So thank you for that.
thank you so much.
And I believe Mustafa is going to tell us about our new fellows and some other details. Thanks.
Thank you, Elissa, and thank you, Paige, and good morning, everybody. Nice to see you all here. So, in order to be eligible for membership in the academy, one has to hold a rank equivalent to an associate professor or higher position, and the candidate must have made a significant contribution to the field. And this is usually evidenced by some of the following categories. Widely cited peer-reviewed publications, a track record of grant funding, editorial board services, or senior administrative roles that have advanced our field. So today, and on behalf of the ABMR leadership and the nomination committee, I'm honored to announce the names of the new Academy Fellows for 2020. And let me see how I can share the list as I read them. Here we go. So we welcome Judith Carroll from the University of California, Los Angeles. Elissa Kirsten from Ohio State University. Chris England from Penn State University. Jennifer Graham England from Penn State University. Mark Hudson Buller from Columbia University. Jennifer Knight from University of California in San Francisco. David Marrero from University of Arizona. Martin Picard from Columbia University. Eric Prather from the University of California in San Francisco. Eli Putterman from University of British Columbia. Tracy Ravenson from Hunter College. Jesse Stewart from Indiana University. And Shakira Suglia from Columbia University. So these new fellows will be listed in the program for 2021, and they'll all be invited to participate in the new member symposium that will take place next year. We're also now getting ready for starting our annual call for nomination for new members for 2021. So please consider nominating colleagues who you think would make significant contribution to the Academy. And the deadline for this will be October 16th. That will be a Friday, October 16th, 2020. We will send some detailed information about the nomination process in the near future. We really hope that you put special effort this year, and like every year, to nominate colleagues who have not been well represented in our Academy, including African Americans and other minority groups. And I thank you for all your efforts in advance, and I look forward to receiving your nominations.
Thank you so much, Mustafa. Thank you for all of your work. This is, the nominations is an intensive job. And we really want to emphasize, that's our main goal this year, is to have each of us think about who might be a member. We want to become more interdisciplinary. We remember that people from underprivileged backgrounds look different on paper, and we're not going to be blind about that going forward. Okay, next we'd like to move to our pandemic data blitz. And I'm just so excited to hear all of you. I know many more of you are doing work on COVID. I really admire the ability to mobilize so quickly with the right measures and to study disasters. And there's no better model for that than Roxane Silver and Alison Holman, who have been the pioneers in understanding mental health consequences of disasters. So welcome, Alison and Roxane.
Thank you. I think Alison is gonna.
And I want to say that we are so dependent on that chat function. Please don't be inhibited. Comment to each other. You can make comments to everyone. This is our dialogue. We don't get to have conversations, during the tea break. So communicate. I will choose a few questions at the end of each presentation and ask you to ask the speakers. But hearing your thoughts and questions along the way is our new way. So let's try that. Thank you, Alison.
Allison's on mute, is she not? I don't hear her.
Sorry, can you hear me now?
You better start over, Allison. We didn't hear you at
Yeah.
all.
Okay. All right. So I'll start over. Can everybody hear me now?
Yes.
Okay. All right. So for the past 27 years, Roxy and I have been conducting research on community disasters and we've learned a lot of lessons from this. And one of the things, several major lessons that we've learned include that it's very important when you're doing this kind of work to have prospective data, that you have pre-event measures of mental or physical health on people so that you can actually see change in people's emotional and psychological response over time. It's also very important to have longitudinal data with immediate response so that you can actually see how did people respond immediately and what are the implications of those responses for longer term mental and physical health. It's also very important when you're doing this kind of work to have both regional and national representation in your sample and to have a representative sample, a sample that represents the population you're trying to make inferences about. And then finally, it has to be comprehensive. There has to, using small cross-sectional studies with non-representative samples, it's an inefficient way to do this, and it was for a long time. It still is in some places a way to do disaster-related research or research on large collective disasters, but it's not an efficient way to do it because there's so much bias inherent in samples and everything. So these are the lessons that we've learned, and we appreciate having an opportunity to share this with you. So in that context, this thing is not moving. Hold on. There we go. So right after the COVID-19 pandemic began here, we realized what was coming down the pipe. We started a new study with the ABMR panel. So what we have in our COVID-19 study is we have pre-health data that was collected on our sample, mental and physical health, that was collected in 2017 to 2018, 2019 for the vast majority. Then in January 2020, we have, you know, the COVID-19 epidemic is like real. We're starting to realize how serious it is. And then, of course, our president declares the emergency on March 13th, and World Health Organization declares it a pandemic. Soon after that, within a few days of that, Roxy and our team, Roxy and Dana and I, began a study in which we developed. We sent a sample out. We had 3 representative cohorts. We wanted to collect the data over time. So we wanted to get snapshots of 3 separate representative cohorts of the ABMR panel, which is a probability-based representative panel of Americans. And so we now have data on between 21 and 2,200 people at 3 10-day representative cohorts over a month period, ranging starting on March 18th through April 18th. So the variables we've included, we have some outcomes such as acute stress, global distress, functional impairment, loneliness, etc., fears and worries, behaviors, physician-diagnosed mental and physical health. We also have some predictors that we're going to be looking at in this sample, including exposure, secondary stress, exposure to conflicting information, because we know there's been a lot of that in this epidemic, in this pandemic. We have residential latitude and longitude so that we can actually identify where people are. And that's really important in this study because what we're looking at is, as you all know, our ability to understand how people are responding depends in part on where they live because people had different orders. California was the first state to have a stay-home order. So different states had different responses to the pandemic, and it's important to pay attention to that. And of course, the love of my heart is looking at time perceptions. I'm very interested in understanding time, and time has been something that a lot of people have commented on being sort of we've lost our sense of time in this pandemic. So we've written a few theoretical papers to articulate what it is we're going to be looking at. Here we have a paper that we published in Health Psych that addresses the issue of media exposure and its use and its function as basically a secondary, a spreader of a secondary pandemic, i.e. the mental health problem that goes along with the COVID-19 disaster. We have a paper about that has to do with the distorted time perceptions that we've been seeing in the age of COVID and what that means for us in terms of mental and physical health. We also have papers on looking at shifting risk perceptions and their implications for downstream health consequences. And then finally, we have a paper that addresses the issue of individual traumas, in particular domestic violence, and how domestic violence has gone up. Rates of domestic violence have gone up, and that has a potential role to play in how people cope mentally and physically in the aftermath of the crisis. So we have some ongoing analyses that we're doing right now, including the first, trying to understand the levels and predictors of distress as the pandemic worsens. So what we show here is the acute stress response across the 3 cohorts. As you can see, acute stress levels in each cohort is rising individually up, and each level of acute stress is higher significantly than the previous one. We see a similar trend for depression, although the first 2 cohorts do not differ significantly in terms of their depression. The third one is significantly different from both of the previous ones. So we see that depression levels are going up as the impact of the pandemic is hitting the country. We're also interested in understanding, as I mentioned before, the role of the media in these health protective behaviors that people are engaging in. How is the media presentation of the pandemic influencing people's behavior and their perceptions of risk? We're also doing studies, we're doing analyses examining the impact of different types of exposures. So community level and statewide policies, how are these things impacting people and their psychological responses to the pandemic? And finally, we're looking at linking responses from compounding community disasters. So with the COVID-19 pandemic, we also have that potentially layered, it will be layered upon our seasonal disasters that we experience. So in California, we've got firestorms that are going to be coming down the pipe, and we also have in the southeast, we have hurricane season. So these things are going to make the impact of the pandemic, or they'll potentiate the impact of the pandemic and potentially give us an even greater causes of distress when people are told they have to evacuate and they have to go to a place where they're at great risk for getting exposed to COVID. So these are very important issues that need to be addressed when the disasters are compounding upon one another. So our future plans, we have a wave 2 data collection plan for after Labor Day, when schools are reopening probably, and some people are starting to go back, move, if people start moving to new places. We're seeking funding for a more longitudinal data collection that will include what we're hoping are waves 3 through 8 that we're planning for the next 5 years. That will see how people are responding psychologically, physically, and behaviorally as the pandemic waxes and wanes and vaccines are developed. And it's very important to point out that the issue of vaccines, our research, not just ours, but our society's research is really important, because as we do science, as we understand better how to create a good vaccine or how to do the testing for the COVID-19 virus, as we're doing that, it's critical for us to understand how can we convince people to actually get the vaccine. Because if people choose not to get the vaccine, that will potentially worsen the pandemic, and that raises all kinds of behavioral health issues that we need to be addressing. So other future plans include reassessing physician-diagnosed mental and physical health in the spring of 2021, examining racial, ethnic, and socioeconomic disparities in early responses to the pandemic and linking them to those physical health outcomes in a year from now. I just received a new intramural grant to address these 2 issues. And then finally, to examine perceptions of the future and their link to mental and physical health outcomes over time. It's very important. As I mentioned, time has been an issue that has been kind of messed up in the COVID pandemic. So it's important for us to understand how these factors are influencing people's perceptions of the future, especially for young people.
Wow.
And with that, I will stop. Thank you very much for the opportunity to share our work with you. We appreciate it. Thank you.
Roxy, it's mind-blowing what you guys have pulled off. There was a comment from Lorenzo, have you been sleeping? Do you sleep? I mean, it's just amazing. I mean, I'm just
No, of course we don't sleep, but do we say that with Tika on the?
Yeah, with you guys around, how can we say that? No, we don't. The time that we don't sleep the most is when we're starting it, because we have to work very fast to get into the field. We have to get our survey ready. We have to get the grant out. We have to get the money. It's a very quick turnaround to get the IRB. But once we're in the field, we can catch up on our sleep a little bit, but it's not always easy. I try to. So
let me go to, the first question is going to be by Howard Friedman. It's going to be about media. And of course, I'll just tell you, I have such a mixed relationship with media. When I'm doing dishes at night, I want to watch Rachel Maddow. I know she's going to make me so angry these days. And then the other piece is just needing to contact what's happening with the changing landscape. I'm crying often, either out of being moved, you know, the kindness of human behavior and the good things that are happening, or just crying because of the brutality we see. And so I feel like we have a responsibility to see what's happening in the media and feel the discomfort and pain. Okay, Howard, you're on.
Hi, everyone. My question is, after a mass shooting or a 9/11 type disaster, there's no rational benefit to keep watching replays over and over. But with COVID, there's new information and new studies every day. So what are the implications of these differences? Like, could it be a real benefit to be really neurotic in this situation?
No.
Roxy, you want to take that?
I'll just say, I mean, I believe that one can stay aware of the information without being immersed in media. And so those of you who know me, I don't watch television. I don't engage in social media. And I think I am informed because I very much monitor how much time I'm spending. So it is really important. We don't in any way want to imply that people should put their head in the sand. It's extremely important to stay informed, but one can go down a rabbit hole reading too much or watching too much television. And what has been really important to recognize about the current situation is that there hasn't really, although there have been new pieces of news, the news has basically been very repetitious and pretty much bad news all the time. It's all COVID all the time and all bad. And there really doesn't seem to be psychological benefit to staying immersed in that. That's not to say that you can't be informed about the latest research. And, you know, Alison and I both warn one another or monitor one another when we do start, you know, reading too much. But I think that as long as you read the science, the research that is informed by the best scientists and stay away from the social media messaging, which in general is filled with a lot of rumor and misinformation.
All right, so this was incredible. There are a lot of questions for you. We can discuss later whether we might do a Q&A on the website, because keep the questions coming, but we do need to move on to the next speaker. So I'd like to introduce Liz Brondolo from St. John's. Liz has been a phenomenal, both empirical and theoretical leader in understanding health disparities and the different factors behind the social determinants of health and social class. So she's been a real guide in this area. Thank you, Liz.
Thank you, Elissa. Let me just share the screen. One second. Okay. Oops. So I completely agree with Alison and Roxy that you need prospective population-based studies, and I'm going to present something that is not that. It's actually a small clinical sample which we did in a hospital, because it actually allows you to go quickly to the CMO and a hospital administration and actually get your results incorporated into their thinking pretty quickly. But also, it's all we could do. So this is a study of frontline clinician burnout during COVID-19 pandemic, and it's a real-time evaluation in the New York City epicenter. And we did this actually as a training project to train our CHIRP fellows, who are residents in family medicine and internal medicine, and our students in psychology at St. John's. And it's a collaboration between St. John's and academic and community medical centers. And this project was funded from the Lang Research Center at the New York Presbyterian Queens Hospital. They funded the behavioral medicine research fellows who do the actual work. So it's an ecological momentary assessment approach to ask questions about clinician well-being and burnout over time as the pandemic unfolded. And Queens, New York was the epicenter of this pandemic for a long time. And we're looking at predictors of reactivity to the increased work demands facing clinicians. And then we do this it's ongoing, actually, it'll be ongoing for a year, but we're looking at the course and predictors of recovery as the pandemic waxes and wanes. I'm hoping it's going to wane, but I don't think that's what's going to happen. So here's the survey. You can see what it looked like on people's phones, because we sent it all out through Qualtrics to people's phones or their computers, wherever they were. And my nephew made a very beautiful logo for us, which is the World's Fair that was in Queens many years ago. And we put it on enamel pins and gave those to everybody. So it was an electronically administered survey. We gave it out at the height of the pandemic in Queens, New York. So, and the survey evaluated burnout and also personal and professional predictors of burnout. And we gave it to all clinical staff, physicians, nurses, trainee physicians, and physician assistants. And this is an academic community hospital. So we began on April 14th, because it took us about 3 weeks to get through the IRB. And we, the time one survey went through from April 14th to May 8th, and it's ongoing every 5 days. So we actually have 14 as of today, but 13 administrations through June. We sent surveys to all clinical staff. The hospital gave us all their emails. Participation was voluntary. So we got 331 people responded, about 17% of the clinical staff there. And it ranged from 17% of PAs to 30% of nurse practitioners and about 21% of physicians and almost 28% of the fellows, residents and fellows, the ones who were there. And we asked burnout. So remember, we're doing this as little diaries, essentially, that they fill out every 5 days. So we only had 12 questions. And the first two questions, which you don't see, is, are you working in a clinical environment, and are you working in your usual role? And then we asked them about burnout, although this is actually at the end of the questionnaire. So the first two, this is a validated one-item measure of burnout. The first two responses are no burnout. Essentially, they feel stressed, but no burnout. Answer three is moderately burned out, and 4 and 5 are potentially debilitating levels of burnout. And then we looked at personal and professional resources that might vary over time and might predict burnout, because there's evidence in the literature suggesting that they're important. The first 4 are self-efficacy in different dimensions like energy, emotional regulation, cognitive functioning, and health, being able to take care of your own health, behavioral habits. Then we have, is the hospital providing us enough support and information to do the job? And then we have meaning of work and professional growth. And all of these things have been predictors in the past. You can see here that the caseload and severity were very high. The blue period is the period where we were collecting data for time 1. We've continued to do it. And this is just before. So you can see the caseloads of COVID inside the Department of Medicine were above 90 actually for periods of time. And they vastly exceeded the beds available in the hospital. The peak here is 88% when we started, and it was still above 50, like 55 at the end of time 1. When you get a really bad flu, about 15 to 20% of your cases in the hospital are from the flu, and you have known therapeutics to deal with it. So here's what we found, and it's not an epidemiological sample, it's a convenience sample, but more than half reported no burnout, but about 1 in 7 reported potentially debilitating burnout. Women reported more than men. Younger people reported more than older, younger meaning 35, under 50 basically, reported more than the older people. I should clarify this. They belonged in a burnout group, so scores 3 or 4 or 5. Nurses and trainees were more likely to report burnout than were attending physicians. And those working outside their usual professional roles were more likely to report burnout than those in their roles. And then we looked at what predicts it, and consistent with the literature, self-efficacy, so more self-efficacy, less burnout, more hospital report support, less burnout again. I was voting for meaningful work, but it was self-efficacy and hospital support. They're all related, but these are the ones that stood out. And then we looked over time. So between 114 and 178 people continue to fill out the surveys. We get about 5, in the first 13, we got about 5 per person because they can skip one and go on again. Burnout is decreasing over time as the caseloads decrease, and nurses are recovering faster than physicians. But everybody but PAs are decreasing. So there's evidence of significant resilience, but also real need for intervention. When we looked at they have also the opportunity to write in things they think we should know. And what's clear is that real-time coaching and supervision may be helpful for those working outside their role. They really wanted, tell me exactly what to do, particularly those people who were in critical care roles who had really not had that recent training because they were GYN or GI doctors now, or nurses in other units. And that may be critical because it improves self-efficacy, which is in itself a predictor of burnout. So there is recovery over time, but prevention may be critical. And burnout prevention and management should be included as part of emergency preparedness operations for medical units. And this is the many people, including Joe Schwartz, our esteemed ABMR member. And these are the physicians and the residents and the St. John's undergraduates and graduates who participated, some of them anyway, all of these people participated, and there's some more. Okay, thank you.
So much, Liz. A question from Daichi.
Sure.
Hi, how are you?
Hi, good. And you?
Did you look by specialty?
Yes.
As you know, the ER physicians, critical care and anesthesia I think they probably had the worst workload with regards to COVID treatment, at least at Columbia.
We did look, and it ends up that they don't differ, which is surprising, but they didn't differ at time 1. What will happen do they recover less? Well, I haven't done those analyses yet, department by time. So we'll have to see.
Thank you. By the way, great work. I forgot to say.
Thank you.
When so we need to move on, but I'm going to sneak in Cheryl Giscombe's question. Cheryl's going to join us next year in person. And she asked a great question, which is what's going into this kind of self-reported resilience? And I just want to say, when we talk about burnout, and it's so clearly the situation that is creating untenable circumstances for healthcare workers, when we measure an individual trait and say, oh, this person's protected because of their resilience, what does that really mean? What is this kind of trait resilience, and how much do you think is trainable?
Well, Joe, you should correct me if I'm saying this wrong, but when you look at changes over time, there's probably about 20% of the variance that is sort of a consistent in trait level, but a lot of it is variation over what the demands are at the time. And I think it's composed of a variety of characteristics, if I'm answering the question right, that has to do probably with external factors in your life. There's a lot of literature on work-life imbalance being a particular predictor of burnout for women healthcare professionals. There's feeling confident about your job. There's feeling meaning in your job. There's perceiving yourself as supported, and physicians feel more supported by physicians in a hospital, and most of the management is physicians. So I think there are both contextual factors and there are individual factors, and then there's home and family factors that influence your resilience. So There's a portion that's you as a person, and then there's a bulk that are probably contextual in general and then specific to the circumstances.
Thank you so much. There are more questions for you. You can answer on the chat line. It's so phenomenal to see your data when we've all experienced what you are going through in New York and hearing from your healthcare workers. Thank you so much for doing this work.
Okay, thank you. Bye.
Bye, Liz. Next, we have Wendy Mendes, and I'm so just grateful and honored to work side by side with her at UCSF. She is a leading experimental social psychologist and psychophysiologist. She studies discrimination and how we influence each other in the lab. She's now branched out and developed over many years a phenomenal platform for understanding daily stress. She somehow developed this with Samsung so that she controls all the data, and she's going to make it public, and she's in many different countries. So I'll let her tell us about her platform, but it's a great opportunity for the field. Wendy, thank you for joining us.
And thank you, Elissa, for inviting me. This is my first ABMR, and I look forward to being with all of you in person next year in Santa Cruz. So like the two previous talks, I'm going to be focusing on some data that collects stress, emotion, and blood pressure in people's daily lives, and focusing both pre-pandemic and post-pandemic using an app-based research study called MyBP Lab. So MyBP Lab launched in March of 2018. It was designed as a 3-week-long experience sampling study where a participant receives 3 notices a day to first provide a sensor measurement, and I'll talk about that in a second, and then also report on their current stress, emotions, health behaviors. Each of the check-ins are a little bit different, and it cycles through 9 different check-ins and then kind of starts up again. There's some common questions that are asked at every check-in regarding stress and location. What's unique about this study is we do leverage a very specific optic sensor that is on certain models of phones and watches released by Samsung. It only operates for the purpose of providing a photoplethysmograph that estimates interbeat intervals, so we can estimate heart rate variability, and also blood pressure. Embedded in this app, we've also put in some cognitive tasks, 6 different ones focused on measuring things like memory, inhibition, so we have a Stroop task, some attention tasks with trails. Also, in different arms of the app, we have stress reduction interventions, so different ways that people can reduce their stress. Along with Eric Prather, we put in a sleep intervention to improve the quality of people's sleep. And since March of 2018, we've had more than 180,000 people download the app and consent to be in the study. And it represents more than 1 million check-ins where people opened the app and provided a blood pressure response along with stress. Now, with this savvy group, you shouldn't believe that I could just measure blood pressure from a sensor at the back of the phone. There's been a lot of crappy sensors out there. So this is some data from our validation study using both lab and field data, comparing the optic sensor to a cuff-based measurement. Not surprisingly, heart rate is excellent in terms of its validity, and systolic and diastolic is good to very good. I will note that you do need 1 external calibration responsive blood pressure for the sensor to operate at this level. So in terms of how we're leveraging the data during this time, a few words about the type of data that we're collecting. The study is approved globally, but we focused our data collection in 8 countries. So more than 150 countries are represented by our participants. But data collection is focused in 8 countries, and that just specifically means that it is available, easily available on the Google Play Store in that country. Though the app only appears in English at this time. But by far, the majority of our participants, as you can see in the figure, are from the United States. So we're going to focus on the analyses today just from the United States, even though obviously we will eventually leverage the global data that we have from the other countries. We have two primary questions that are guiding our current analyses as it relates to the pandemic. The first question is how the pandemic has affected stress reports and physiology, specifically comparing spring 2019 to spring 2020. This is cross-sectional. Typically, these are different people because of the 3-week study, but we do have actually about 1,000 super users who have been in the study for both times across that entire year, but they actually are dealt with separately and not in this analysis I'll talk about today. So we're comparing two different time points where we can hold season, we can control for season, but we're asking specifically about geographical and temporal effects using self-reported zip code of our users, and obviously the temporal features as a pandemic affects your specific region. The second question that we're looking at is factors related to developing cold and flu symptoms, so specifically COVID-like symptoms. And we're going to be looking at what we think of as the most obvious potential predictors that we're seeing in the literature. So we have, for example, blood pressure levels as potentially a vulnerability factor of developing COVID-19, age, socioeconomic status, race, ethnicity. We have BMI, gender, and of course the psychological factors like experiences with discrimination, asking if those kinds of psychological factors may lead one to be more likely to developing COVID-like symptoms. So just to give you a sense, so I was struck by, I loved Alison's talk and going first because it reminds me why my data are good and why they're bad. So I'll start with the bad, obviously not a random sample. And so we think a lot about representativeness, who are our people who download this app and want to be in this study. It turns out I didn't know this ahead of time, but Samsung users tend to be primarily male, and that's true in our data as well. I would also characterize our samples every quarter I look at the data, and I would say it's bimodal in terms of the type of person who downloads this app. So to be in this study, you get your blood pressure, and the only way to ever use that optic sensor to give you a blood pressure reading is to be in the study. So one group of people are people really who care about their blood pressure. They tend to be skew older. And then we have these like weekend warrior types who, you know, the 32-year-old male who's doing marathons on the weekend. So that characterizes some of our participants. But we do tend to have sort of midlife, 43 tends to be around our average age. And in the US sample, it is primarily white, but not terrible representation for African Americans, Asians, and then in a separate category, those who identify as Latinx. They're primarily non-smokers, even though I just said that about the weekend warriors, only 40% of people call themselves regular exercisers. In terms of self-reported health, we have a fairly normal distribution, most people saying they're in good health with the tails represented, and this is income. The last figure is income, and that's fairly normally distributed in terms of our participants' self-reported income. So I wanted to just give you a quick snapshot. This is from 1 week of user data. This map is showing the number of people who are participating as an active user in this study. And you can see that the purple represents more users. And so not surprisingly, you have California, Texas, Florida, kind of your big states, there are more users. But this is also sanity check for us in terms of, right, we don't have a ton of people in sort of that Midwest region, so we think about that a lot. The target for this analysis, though, that we a priori specified in terms of spring 2019 and spring 2020, we have an effective sample of just over 19,000. We had very specific criteria before we pre-selected those people to be in these analyses. Just as, let me just back up and say we have some principles that guide all our analyses. Those principles include that anytime we identify a sample that we want to analyze, we first extract a 10% random sample. We build all our models on that random sample. We also feel unconstrained to do exploratory analyses, but once we lock in our data analysis registration, we don't stray from that. So the analyses that I'm showing you is on that 10% random sample from those 2 spring periods. At every check-in, we ask participants, how stressed, anxious, overwhelmed are you? We use multi-level models, so each check-in is nested within person. And again, just as a sanity check that we could see from the 2 previous presentations, people are obviously reporting more stress, anxiety, and being overwhelmed in the spring of 2020 versus 2019. As it relates to cold and flu symptoms, same 10% random sample, on every 3rd night, we ask about physical symptoms. There are actually 5 categories of physical symptoms. We're going to focus here on the COVID-like symptoms of cough, sore throat, fever, chills, and or other cold and flu symptoms, and people report from 0 to 4. At a different check-in, but also asked every 3rd day, we ask David Williams' everyday discrimination item, where we ask, did you experience any unfair treatment today? And then use a checklist. And we ask, how much did it bother you, that unfair treatment? And people rate it from 0 to 4. We first just looked at the overall relationship between how bothered or your reactions to discrimination and symptoms. And we see a really hearty effects or association between people experiencing or being bothered by discrimination and reporting more cold and flu symptoms. Interestingly, this is not moderated by year. We see this effect in 2019 and 2020. And if anything, that tells us how important it is to have these prospective data that reminds us that these relationships exist, though they might be exacerbated. In this case, we don't see that in the 2020 data. We do find that this association is moderated by SCS, though, and that's the graph that I've plotted. That we chose the third rung from the bottom versus top, just as a best representation of 1 standard deviation, low SCS, and 1 standard deviation above the mean of high SCS. And what you see is for those lower in SCS, the association between being bothered by discrimination and reporting of flu symptoms is exacerbated. Our future analyses, once we've finalized our models, is we're going to be looking at temporal and geographic maps, examining changes in self-reported stress and blood pressure as the pandemic waxes and wanes in specific area, again, focusing on participants' self-reported zip code as their location. We're pairing this current data with lots of exogenous data sets, including economic factors, racial unrest, and of course the pandemic. And with that, I just want to acknowledge the UCSF Stress Network, which I co-direct with Elissa Epel, who's really the brainchild behind this work, and all the members of there, and especially NIA, who gave us the funding to run this network and got us excited of thinking about measuring stress in all of its different facets. And thank you for your time.
A question from Christy White.
Yes.
I was just curious if whites were excluded from the discrimination analyses.
They were not. No, whites are absolutely included in that analysis.
Did you want to mention something, Wendy, about racism versus discrimination?
No, well, I'll just say I was mentioning to Elissa and team the other day the importance of measuring racism specifically, which looks different than kind of everyday discrimination. Many people here might have seen that in their own data. So I think that ability to sort of more specifically identify those feelings of rejection because of race. And of course, that's in everyday discrimination. I'm not sure it's always picking up on that specific feeling of racism. And I think we have to do better with measurement there.
Thank you so much, Wendy. There's clearly so much to learn from this amazing data set. And you are just such a generous, service-oriented researcher. It's wonderful that you are, you have so many students involved and that you're gonna be making this public. This is just one snapshot of her data. It's quite multi-layered and over many different countries. And I think that the idea that infection or symptoms are predicted by something like discrimination, is the world is going to be very interested. It's the most important demonstrations now of how our immune system is responding to our social environment. And so thank you for your great work. I know we'll have hear more of this type of data from many of you who study the immune system and symptoms. So Wendy, there may be some questions for you to answer on the chat line. I need a vote, guys. So it was a very civil schedule, and we had a 5-minute biology break for metabolic needs, et cetera. And I do want, the whole 45 minutes we have left, 40 minutes we have left to be present. I want to make sure we have time for discussion. And so we either stop for 5 minutes and come back, and then we'll have about maybe 8 minutes for discussion at the end of the whole symposium, or we blaze through and people turn off their screen if they need to take a break. What is next is our talk by Diez Roux. She is actually a member of ABMR, so I presented her as a guest, but she's one of us, and we're so happy to have you back this meeting. So I would like a raise of hands. Do we want to take a 5-minute break and have less discussion, or do we want to just say, everyone do what you need at the time that you need it? Okay, so I'm seeing nods for the latter. So we're gonna move on. Anna is the Dean of Epidemiology and Public Health at Drexel, and I put on the website her recent note to her department about foundational epidemiology and how it's being both demonstrated and challenged. And I should mention that on the website, Elena Frommer, who you might see her face, she is my superpower. She's the reason that this meeting happened and the reservations happened on time. So she's one of my lab managers, and she's helping with ABMR. And so she put on the website yesterday some really great readings. There's some foundational readings from Wendy helping us understand discrimination and cardiovascular effects. So Anna, we would love to hear from you now.
Sure, can you hear me okay? Yes? Okay, good, because I'm on the phone because my internet is down, so I hope this works. So first of all, it's great to have the opportunity to be with you. As Elissa said, I am a member of the association, and I have been to a couple of meetings, but I haven't been there in quite a while, so I really appreciate becoming reconnected. This is a great group of people, so I'm delighted to be able to share some thoughts with you. And so what I thought is I would just share a few reflections sort of on the links between COVID, inequities, and population health. And I've organized my comments into 3 areas. First of all, talk a little bit about what the pandemic has highlighted that we already knew, what the pandemic has highlighted about opportunities of new things that we could explore and learn from this pandemic that have a broader implications for population health. And last but not least, what could be some paths forward after the pandemic for population health in general, building on some of the lessons that perhaps we're learning from what we're seeing. So starting with the first topic, what has the pandemic highlighted that we already know? Well, for me, I think a key thing that the pandemic has highlighted is the profound influence of social structure on health. It's obviously not news that diseases are socially patterned. We have seen this again and again. We saw this illustrated very clearly with COVID-19, a situation where initially cases were more common in higher SCS populations, higher SCS neighborhoods, potentially because of travel, et cetera. But very rapidly as the pandemic evolved, we saw the common situation where diseases become clustered in disadvantaged groups. And in addition, of course, the pandemic has also highlighted the sort of the intersecting but also distinct impact of race and social class. And this has been, it's been really remarkable to see how much attention this has received in the media. Even though, of course, to us, none of this is new. I remember writing a paper maybe 20 years ago on tuberculosis and neighborhood poverty in New York City that sort of made the same points. So it's been around for a long time, but it's great to see this highlighted. Of course, the mechanisms are many, you know, I'm sure you've all thought about this: exposure to the virus, differences in exposure to the virus, crowding, jobs, types of jobs, commuting patterns, differences in susceptibility to the virus, who becomes infected after they become exposed. Members of this organization have done so much research showing the impact of psychosocial factors, Sheldon Coe and others, on the development of infection after exposure, and also the impact of social factors on severity of disease and case fatality. And this has to do with pre-existing conditions, which are themselves socially patterned, but also with the presence of other stressors, healthcare access differences, and differences in access to treatment. So I think the pandemic in this sense has been a very vivid illustration of how health inequities appear and how they are driven by multiple factors operating at different stages of the disease process, from exposure to infection, to severity, to treatment, to death. And I think because of the prominence also of the race differences, and I'll come back to this, but also intersecting with the movement, that the social movement against racism that we have seen over the past few weeks, really demonstrating sort of how these interlocking systems of inequality, racism, and segregation generate these health inequities, and the need for structural approaches if we are going to really address these health inequities and improve population health. So that is something that we already knew, but that this has illustrated very vividly and put into the public discussion in a way, I think, that has been remarkable and unprecedented in many ways. So it's an opportunity, I think. What about things that we don't know? Well, I think we've seen in some of the presentations that we had earlier, the many opportunities that there are for understanding, a lot more of the specificity of, how social, behavioral, and biological factors affect who gets infected, who develops severe disease, what kind of disease they develop, how quickly. I mean, it's remarkable how little information we have on all of that, given the state of the pandemic that we're in. So there's a lot to do there. But I think even beyond that, I think what we are seeing through the response that we've made to the pandemic, these social distancing efforts and the economic shutdown, basically, is in an enormous natural experiment. And certainly opportunities to look at the health impacts of income loss and job loss and the health consequences, both mental and physical, but also other aspects. How has working from home or stay-at-home orders, or how the economic shutdown itself, the slowdown of economic activity with all that means, how has it affected sleep, leisure time, other social interactions, diet, and physical activity of people. And I think one could envision both positive and negative effects of this. And I think we have to be open to that. There's, intriguing literature, for example, suggesting that sometimes economic slowdowns can be good for health because people are not working overtime, they're less stressed, they have more opportunity for social connections, they consume different kinds of things, and sometimes it's better. So I think really using this opportunity to think creatively about how we can learn about the links between our economic system and our health is really interesting. And I think there's tons for social and behavioral scientists to study by taking advantage of this natural experiments. And the last point that I wanted to touch on is sort of the idea of paths forward for population health. I think, one of the remarkable aspects of this experience has been how we have seen the willingness to adopt far-reaching social action to protect health prioritized over the economy. And I think obviously the fact that this is an infectious disease and the fear of contagion has probably had a lot to do with the willingness to engage in this, these dramatic actions. Other diseases hundreds of thousands of deaths due to air pollution or violence or automobile crashes have not motivated any sort of response anywhere near this. So I think that's an interesting thing to think about. But I think also what this has shown is the real possibility of social change and social action to protect health, and has demonstrated that. And I think the fact that we had been through this also gave greater relevance to the social movement against racism that, of course, was triggered by the most recent examples of this repeated violence against African Americans by the police, which of course has been happening for a long time, but this acted synergistically with this recognition that we can make social changes. We have made social changes as a result of our response to the pandemic, and I think that has given these movements perhaps more power and more relevance. And so I think basically, there are two paths forward. One path is where everything continues as it was. Maybe we get a vaccine next year. We go back with some struggles along the way, but we're back business as usual, but with COVID in the mix now as another infectious disease that we have to worry about. Or perhaps there's a different path. And what would that path look like? Well, to me, first of all, it would have a recognition of the need for solid public health infrastructure and a coordinated national public health system. I mean, this has been incredible to see how the United States, such a rich country, a leader in the world in public health, CDC, for example, created to grapple with a pandemic like this, has really struggled to coordinate a national response. So a public health recognition of the need for public health infrastructure and a public health system that recognizes the role of social policy and the role of health policy in health as two interrelated aspects, and that of course connects to research in a way that's much more coordinated and much more rapidly responsive to population needs. But also, a greater recognition of the role of these systemic factors that impact health and quality of life: inequality, racism, segregation, work conditions, and the grappling with the fact that the social and economic systems that we create and sustain are major drivers of health and health inequities, and perhaps an opportunity to think differently about our values as a society, our priorities as a society, and the implications that that has for how we're organized and for health and many other things beyond health as well. So I'll stop there. Thank you for the opportunity to speak to you.
Thank you so much, Anna. That was so rich, and you posed the most important questions that we're grappling with. How do we not return back to business as usual? The businesses are suffering. The big, multinational corporations are going to come after us with consumerism in such a strong way, because we are now a society with such elevated depression and anxiety, and that drives the false solutions to eat, for example, and to buy things that let's just say create the climate change and climate crisis. So I would love to hear in the chat line or some other people speak up about ideas here. Robert Lustig, if you have a short comment here, he wrote a book exactly on this, about the society's entrainment of our reward system and hijacking it for commercial gains.
Right. Well, thanks so much, Elissa.
This is Robert, your audio. Okay, Robert wrote a book called Fat Chance on Obesity, and he's a doctor who's been shown us the toxic effects of sugar, and his newest book is The Hacking of the American Mind. That wasn't an ad, just to let you know the content.
Thank you, Elissa. It's dopamine and cortisol together. Whoa. Something.
If your audio is not working, we'll have to resort to chat. What? Okay, let's have someone else comment here, and maybe Robert will come back. I mean, we can all watch and say, I hope we don't return to business as usual because it wasn't a very healthy society in the first place. So that's the, you know, it is to be determined how we return. Tom, I'm going to have you ask your question out loud, Tom Kmark.
Oh, thank you. Anna, I just was wondering, given your work on community structuring of SES and so forth, I was wondering if you had any thoughts about how we might study individual differences in local, political, and statewide political and social response to the epidemic and their effects on the growth of the virus.
Well, that's a great question. I mean, I think we should really try to capitalize on the heterogeneity that there is across the US, for example, across states, across cities, in the things that have been done and are being done in response to the pandemic, to sort of help have sort of more of a multi-level understanding of how factors at different levels are interacting with each other. I'm not sure if this totally addresses your question, but you know, we see different patterns in different places. Even in terms of the neighborhood patterning of the pandemic, we see it evolve and change over time, perhaps partly in response to what cities are doing. So I think there's an opportunity to really take a look at that. You know, for example, initially, if you looked at the patterning of testing, it was quite, you know, there was more testing in higher SES neighborhoods for a number of reasons. And over time, this has evolved and changed. And, you know, this happened in response to actions that cities and health departments took. So trying to understand the links between the decisions that were made and the patterns that we see at the community and the individual level, I think could be very interesting areas for research, because they could tell us things about, you know, other strategies that we could use to reduce health inequities and more generally.
Thank you so much, Anna. I'm going to hold on to Susan Chakowski's question because it frames what we want to talk about in our last 10 minutes. Okay, I'm going to move to John Ruiz. Thank you so much, John. He's going to comment on what he's seeing from his lens as someone who studies the Latinx paradox and health disparities. John is the incoming president of the Behavioral Medicine Research Council, as well as many other important roles. John.
Thank you, Elissa, and I just have to say it's great to see everybody. It's heartwarming to see other humans. I love my family, but it's great to see other people as well on occasion. I hope I'm able to share my screen with you. Like a good academic, I have 5 minutes to speak, so I've prepared about 30 slides to share with folks. And so let's ask you to sort of think about and talk a little bit about the experience of Hispanics in the context of COVID-19. And like all of you, we see the headlines, and as several people have already pointed out, the incredible disparities in incidence and outcomes, and the disproportionate burden experienced by people of color, underrepresented communities, and those in the lower SES brackets. And as Anna just mentioned, a lot of times there's that intersection point between SES and racial ethnic status. As we see a lot of these headlines, I think about my own work in thinking about paradoxical outcomes, and I was curious as to sort of, well, is it following the trends or is it not? And so, of course, from a risk perspective, Hispanic Latinos experience disproportionate risk, just like most populations, particularly the issues of low SES and exposure and risk for transmission. That's everything from employment to neighborhood proximity issues, and then sort of along with SES is the issue of daily acquisition of resources, living meal to meal, day to day, not being able to afford to travel to Costco or living in food deserts and whatnot. And communities themselves having housing closer together, all these things facilitating transmission as you would expect. And then there's, for Hispanics and Latinos, what we often think of as a resilience factor, the importance of strong social networks, social bonds that are culturally driven, that in the era of, or in the context of an infectious disease may actually facilitate worse outcomes, higher incidence and worse outcomes. So there's now emerging data from CDC, from states, from different locales. It's of varying quality. It's at some point we can do an epi of our epi work and take a look back at how we did in this context. But some of the latest work has begun. Some people may have seen the published reports from this past week, looking at racial ethnic demographics and COVID-19 incidence. And so this data captures the discrete period of January 22nd through May 30th and includes some 1.3 million lab confirmed cases. And so this is an important report in that it went ahead and didn't just sort of do a records-based calculation or aggregation, but rather looked at a specific type of lab confirmation. From that, about half of that data included race and ethnicity. That's something we got to get better at, obviously. But if we look at that data, it's exactly what the risks would predict. Hispanic Latinos, as seen there by that arrow, have a very high incidence of disease. So a lot of transmission, high infection rate. And the black bars next to that, next to the red bar, which represents the infection rate, the black bar represents relative representation in the community. So Hispanic Latinos are about 18% of the population, but account for about 33% of confirmed lab cases that are aggregated by the CDC. That is probably, I should note that that's probably an underreported statistic. 2 other studies have emerged in the past few days that suggest that probably what a lot of us suspect, which is that the equity in testing is not equitable. That there are important disparities in who is being tested. And so when we have a tested sample, it's not necessarily representative of everybody in that pool. In terms of outcomes, one of the things we've learned about Hispanics and Latinos is that oftentimes risk factors aren't necessarily congruent with outcomes. We see this in heart disease, cancer, mental and physical health across the board. And so the question is, which pattern is going to hold true here? Again, this is sort of, it's like watching my son's 8-bit video games. It's the resolution is poor still, but you can begin to make out patterns and start to see trends. In terms of determinants, the population level determinants are higher infection rates is going to usually result in greater cases. The issue of SES healthcare access, but not just access, the quality of the healthcare received and the timeliness of it. The role of age and any pre-existing conditions. Hispanic Latinos have several of these risk factors. They have the high prevalence. They have the SES issues, as we've discussed, and high rates of pre-existing conditions that are known to be known to exacerbate these outcomes. At the same time, at a population level, Hispanic Latinos tend to be a younger population, myself excluded from that. There's also these sort of interesting sort of social wrinkles, and that's things like likelihood of living, say, in a nursing home. One of the things that we've seen is that with an infectious disease like this, there's clustering in certain locations, and so this is potentially an offsetting factor for Hispanics and Latinos, that they have this, that they're not as clustered in, say, nursing facilities, tertiary care facilities. And I'm going to raise the issue of social support. And I know I cited it earlier as a potential risk factor, but we often think in times of illness, it's important to have support. So perhaps there's another role for it. So this is data on hospitalization. This is coming out of the COVIDNet CDC surveillance. This is a really small sample of some 580 lab confirmed cases. But what we see here is Hispanic Latinos having a relatively lower percentage of hospitalization relative to their percentage in the pool. So lower likelihood of being hospitalized. In contrast, non-Hispanic Blacks have a much higher rate of hospitalization amongst those infected. This could be any number of issues. It could be a good thing, it could be a bad thing. We'll have to sort of wait and see. But in terms of mortality, I got up East Coast time this morning just so I could pull the latest CDC numbers on mortality from the weekly report. This is ending June 20th. It has some 107,000, almost 108,000 mortality cases. The black bars represent the weighted distribution of that particular group within the population. The red bars represent the distribution of COVID deaths. For non-Hispanic whites, for non-Hispanic blacks, we see disparities. We see an over-representation on the mortality side relative to their representation in the weighted population. But for Hispanics and Latinos, we see this oddity over here of a substantially lower than expected mortality rate. This is fairly robust. I collect these data each week. It really, as the number of states increases, this week's data has 43 states plus Washington DC in it. So still not every state is accounted for. But as that number grows, the one group that doesn't seem to be shifting in terms of its percentage of the mortality is Hispanics and Latinos. Obviously not optimal, but paradoxically incongruent with their percentage of the population. So all this just is part of an emerging picture of Hispanic infection and survival incongruence. Obviously it's not optimal, but it makes us maybe pause and think about whether one point in the disease necessarily predicts the next point in the disease equally amongst the population, or whether there's heterogeneity in those trend lines. At a broader level, I think it also should be noted that a risk factor, or a factor may be a risk factor at one point in the disease course, but potentially could be an offsetting resilience factor at a later point in the disease course. And perhaps this is what we're seeing with Hispanics and Latinos in social support. While those social ties facilitate transmission, they may also be helpful in recovery. I'm gonna go ahead and leave it there.
John, you have a very big job answering the text line. We have chat questions, which are huge, so good luck with them. We'll pick up where you stop during our discussion. I want to move on to our, we have two more speakers, and I want to make sure they get their 5 minutes. So I'm going to turn this to Julian Thayer. And I just want to say there was a moment when we were together last year, Julian was talking about mechanisms of racism, and he looked out and he's like, guys, you know, you didn't exactly say this, it was like, I've been with you for decades, you're all white, I want to help you understand this. And you can't fully, although we are starting to more, and wow, we actually doing better in diversity. And I just want to point that out. My point in talking about the history of the slow inclusion of women was, now look where we are. We're doing great in that. And our next step is inclusion of diversity. If we're really going to understand these issues, we can't do it from this ivory tower as a group of, you know, white privileged people. And if you read the chat line, I mean, boy, this is juicy. So let's get there. And we will most definitely have pick up this discussion of how we can do better research with people, not on them, as Lauren Whitehurst said. Lauren is one of our young scholars who will join us next year. She has developed the field of sleep equity. So you can wave your hand, Lauren. Maybe some of you can see her. Julian, you got the floor.
Yes, thank you. It's great to see so many of my friends and colleagues here. And I didn't prepare any slides. But what I want to talk about is a sort of a meta issue with respect to behavioral medicine research and looking at racism and social inequalities. So the social commentator D.L. Hughley has said that Black people are always the first suspects in their own deaths. So I want you to think about that. There's a whole blaming the victim kind of scenario that we have to be very mindful of as we go forward as researchers. Now, I heard an interview with an African-American researcher from USC with Katie Couric, and his explanation for the health disparity was genetics and diet. Now, that's blaming the victim. And it was very discouraging to see an African-American researcher making those kinds of statements. So in terms of blaming the victim, as we go forward, we have to be very careful in how we couch our work, because if we start to put it into a kind of a deficit model, this has plagued all cross-ethnic comparisons for years, and you have to be very mindful of how this is framed. And I mentioned that this researcher, this African-American researcher from USC, was on this interview. Just by having a Black person on your team, it doesn't mean that they're going to understand what's going on, because his model, what he proposed was this whole Middle Passage idea that the slaves that survived the Middle Passage retained water better. There's actually no evidence for that at all. It's scientifically unsupportable. So, but it fell into a category of blaming the victim. And as we move forward, we need to understand that as we do this research, we have to be very careful how we treat this topic and how we address it, because I know that many prominent African-American researchers will recoil to any attempt to blame the victim. So if we want to get into those communities, we need to be careful how we frame it when we go into the communities, and not say that this is, a self-handicapping that we are doing. So now I see a comment from Bob Lustig. He says he disagrees. You are what you eat. Yes, Bob, absolutely true. But the food deserts are not caused by the Black people. So I agree it's what you eat, but when this person was talking about salt being associated with hypertension and COVID risk, there's no evidence for that. You're absolutely right that you are what you eat, but because of these food deserts. So the other issue I want to bring up is related to the issue of the effects of the victims of discrimination, as well as on the perpetrators of the discrimination. That is to say, there's a contingency between one's actions and their consequences. And for many underrepresented minorities, they are paid less for the same work, and they are punished more severely for the same crimes. And this leads to a breakdown in the contingency between their actions and their consequences. And this can lead to senses of hopelessness and depression that was represented in the type of data that was presented earlier. Now, on the flip side, what does that look like from the people who are on the other side of that contingency, where they are, from an equity perspective, rewarded more for their work and punished less for their bad behavior? So this leads to a sense of entitlement and a sense of impunity. And you could see that in the face of the officer with his knee on George Floyd's neck. And that impunity that leads to has negative consequences for those individuals as well. So that discrimination, as I told Elissa the other day, so anger is the poison you give yourself and you hope the other person will die. So it hurts not only the person that you're discriminating against, but it also hurts the people who are being discriminated, who are doing the discrimination. And I think it's important that we try to stress that this is not good for anybody. And there's a study from the Project Implicit. Leitner is the first author of the study, where they showed that explicit bias was associated with greater cardiovascular mortality, both in those individuals that were the subjects, the victims, as it were, of that discrimination, but also the perpetrators. So that's the type of information that we need to make available so that we stress that we all benefit when we move towards a more equitable dealing with each other. So for the sake of time, I will stop there, and thank you for allowing me to speak.
Oh, thank you so much, Julian. You play such an important role in our society, and we overburden you. You've taught us so much, and we're so grateful, and it shouldn't have to be that way.
Thank you.
All right, I'm feeling emotional. I want to move on to Michael so he can have his 5 minutes, who we are going to go till 10:50. If you need to leave at 10:45, you are very welcome to wave and leave. I purposefully didn't stop us right at the hour. Our new lifestyle of on the hour meeting, Zoom to Zoom is killing me. I'm so depleted by it. So at least you'll have 10 minutes if you can stay till 10:50 before your next thing, if your bladder will last. Okay, Michael, you're on. I've asked Michael to speak about climate as a context for us to think about now, not when it gets urgent, because it's here and it is urgent. Michael is the past president of SBM and among many other important service roles. Thank you.
Unmute, Michael.
You're muted.
Well, we heard him earlier today.
Okay,
There he
you,
is.
can you hear me now? I'm sorry. So as my role as president of the Society of Behavioral Medicine, I launched an initiative to identify the provocative questions in behavioral medicine. And I asked our membership and others to envision those areas that they're really interested in working, and what kind of research they think are really important. And we got a great response. And what I want to talk about a little bit is the other pandemic, and that is climate change, and how it really also relates, just as COVID-19, to exacerbating health disparities. So let's see what I can. Okay, so these are what you see in those bubbles. These are the areas that broad-based categories that our respondents think are the most important part for our community to work in. And if you look at this, and this is really sort of think about it as a 30,000-foot view of how we can attack these kinds of problems that people have been talking about. So it could be COVID-19, it could be future pandemics, it could be obesity-related changes, it could be climate change. So I just use climate change as a use sample to see how we can really push this forward with the lens of health inequities. So if you, for example, think that if you're interested in tailoring and how do you scale up our interventions, then you can work in this, and your focus can be on health behavior change in response to pandemics, for example. It could be in response to climate change. Inequities, we've been talking about this a lot. What are the health disparities that are influenced by climate change? Which groups are most affected by this? I mean, there will be, and you will see this in a second, there are parallels in terms of how the pandemic has influenced and magnified health disparities, as we have heard, and we will see the same and has been seeing similar kinds of developments within for climate change. You know, what kind of methods are best suited for sustained behavior? Put in whatever kind of area you're interested in. Here it is climate change. We have emerging technologies. We're having AI how do we integrate, for example, our new methods and behavioral medicine into the larger group, into the society. We have to work not only as behavioral as behavioral medicine researchers alone, but we have to connect to other groups. In the chat box, we heard about that we need to involve the communities, and that's absolutely right. We need to do that, and I would actually say we have to go even further than that. We have to reach out internationally, because the problems that we have in our country are just as prevalent in other countries too, and we can learn from their approaches. So here is the slide, the health disparities that are magnified, and within the pandemics, you have seen it already. And I'm just repeating what others have said. For climate change, you have similar kind of issues. There is an impact on pre-existing conditions. Well, who has the most pre-existing conditions? Those that have less access to healthcare, who have less access to nutritious food, who work in jobs that are hazardous. Those climate change and as well as the pandemic kind of related changes provide increased stresses, as we have seen. And again, they are magnified within for those underrepresented communities. And then we also have economic stressors. And as I said, it's not only in the US, but also globally. So what are we doing about this right now? We have, there's actually one good thing, and I want to share this with you. So this is from the Yale George Mason University Institute on Climate Change. So how much are people really alarmed or concerned about climate change? And the good news is that Americans now have worried about it more and more. The alarm group has tripled over the past five years. The dismissive group that are doubtful and or disengaged is small, but they're very vocal. And the other news that came out, and there are a number of papers there, and I think I put one into the shared drive, was the evidence that minority groups are just as concerned about climate change as non-minority groups. So this perception that only white people are environmentalists is really not true. And I think this is an important point for us to consider, that we are all in this together, and we are all concerned like that in a similar kind of way. So what are we doing about this? We have SBM in the NCI has put together a climate change initiative, and we have started to create a working group. I will mention that in a second. We have also done 2 foundational webinars that I all invite you to attend. The first one is July 31st, and these are the speakers. And the second one, the foundational webinar, is hosted by Kara Hall from the NCI, and it's Climate Change, Behavior Change, and Health, Tackling the Global Challenges Together. So these 2 webinars will really focus the participants and everybody else about the importance of climate change. And as I said again, we can really add this to any other kinds of issues that concern us. And then the working group on climate change and behavior and health has these 4 subgroups, and one of them, particularly important today, is the health inequity subgroup. We have a policy and advocacy subgroup. We have a communications related subgroup, and then the basic behavioral science kind of subgroup. So just stay tuned, mark those calendars for those webinars, and then I invite you to become advocates of in this work. Thank you.
You're muted, Elissa.
All right, we are at the end of our time, and it's very hard to end because this was so rich and the discussion was so good and the chat line worked. I mean, I'm very happy that we that all of you are here and that we've shared this little bit of time together, and it's been very impactful. We will summarize some of these issues and the resources on the ABMR webpage. That's 2020 meeting. So this, I do want to say that the issues that were raised in the chat line, we don't have time to really hear the discussion, but Susan Chakowski talked about our partnering more with researchers who are looking at systems and policy. And Sue Everson Rose also talked about how we talk. Like, let's look at how we talk about people and try to really change that. We're not just these, objective observers of people. We are active players, and we want to embrace communities if we really want to help them, and not study them in a way that we're trained to, really. I mean, we're kind of trained in a way that is not rising up to the challenges that we face right now. I want to point out that next year we have Kelly Brownell, who will be talking about food as an example of partnering with agricultural food industry and the kind of medical establishment in terms of obesity, and how he's made gains that way. So really thinking about strategic research, how we can ask questions and then deliver answers, working with cross-sector partners to make our work more impactful. Margaret Chesney, you have to wave, Margaret. I'm so glad you could come back to the meeting. She spent a lot of time on Capitol Hill, and her point is similar to the rationale for the Behavioral Medicine Research Council, which is we have a lot of good behavioral medicine interventions that get published and ends there. So she is helping rewrite policies, and this is a time of change, and people are listening and welcoming her and our field's input. So I hope to hear from all of you more in the media. I think that we have really, really important voices right now. And it's wonderful to see you all. Thank you so much for attending. This video will be on our website. Have a wonderful day.
Thank you. Thanks.